I'm pleased to be asked. What a all-star panel with Dr. Dickerson and Sean Kelley and uh, Dr. Makary, and good to see you all. David, thanks for giving us this opportunity. Uh, I believe the theme for today is innovation, which in my mind, and I think the mind of the other panelists, is equivalent to disruption. And I'd like I'd like for each of the panelists, starting with you, Cristin, if you don't mind, just tell us a little bit about your background and what you think the most disruptive and innovative facility, sort of, or other disruptive modes you see going on in the free market space right now.
Okay, I am a 25-year radiologist. I have been in the cost containment space my entire career. I've always been with multi-specialty groups. And what we're doing now is we're trying to shift about 80%, the appropriate 80% of imaging to outpatient imaging centers rather than the higher cost hospital imaging centers. And that can, over the next 10 years, if we can accomplish that, that's going to save about 8% in total healthcare spend. And that's a huge number. The thing that excites me, new technology in my field, we have the technology to do great diagnostics, to do great screening. New technology to me is getting it out there to people affordably. And the really exciting thing, we all hear about artificial intelligence, and everybody thinks that that's going to replace me. It's going to replace radiologists, and it's going to be reading chest x-rays. But what I'm seeing is artificial intelligence applied to existing technology. And this is an example. One of the things that independent imaging centers are struggling with right now is cost containment. And it's because the cost of helium is going up to cool the magnets, cost of labor is going up. It's really a challenge for them. And so what artificial intelligence is, we have two companies right now that are vendor neutral and can take an existing older MRI machine and basically increase the throughput by 3 and to make better images, make it a 1.5 Tesla magnet, the images, the equivalent of a 3T. And what they're doing is they're just taking a couple of pulse sequences and recreating the other pulse sequences. So it's really exciting technology, and that's going to enable us to continue to bring down the cost of care in my space.
That's interesting. I've always thought one of the more disruptive things about, Cristin, what you're doing is so many patients enter this disease cesspool that we call our industry in the imaging center. And if they discover there that they actually can obtain affordable imaging, I believe the light goes on in many people's heads that, well, this wasn't the $5,000 MRI I thought I was going to have. And I believe that people wake up and begin to wonder, are there other affordable, high quality options out there? So I've always thought one of the more disruptive things about what you're doing is at least turning that light bulb on, or giving people the opportunity to kind of wake up and at least give that some consideration. Marty, why don't you go next? Tell us about yourself. Not that you need an introduction. Tell us what's going on with you and what your views are about the state of innovation and disruption in this space right now.
Well, thanks, Keith. It's great to be with you, and really cool to be with these other panelists here. Thanks, David, for hosting this. So my interest has been in rebuilding the public trust in American hospitals and in the medical profession. That great public trust, which has an incredible heritage, an amazing heritage that's intertwined with altruism, morality, ethics, our great American spirit, a ancient tradition of the medical profession of taking care of all of those regardless of their ability to pay. That public trust is now being violated as it's never been violated before, with price gouging and predatory billing. So most recently, in response to the comments, which I was very pleased with, from this message of the sort of a compendium of our research over the last 3 years in the book, The Price We Pay, that I wrote and came out last month. What my team has been doing since then is developing measures of billing and pricing quality. We've got measures of cardiac quality. We've got measures of surgical quality. We've got measures of primary care quality. We've got all of these measures, mostly immature, oftentimes inefficient, too many, sometimes more costly to measure than they provide any benefit. And so this entire measurement industrial complex, the good and the bad of it, has been entirely focused on complications of care that are physiologic. And my feeling is that billing quality is medical quality, and financial toxicity is a medical complication. And taking care of a person is taking care of the entire person. As you say best, Keith, and my favorite quote that I often cite from you is, I don't understand how a doctor takes an oath to take care of a patient at a time when they're vulnerable and then ruin their life financially. And so we've developed 6 measures of billing quality that we anticipate, and this is unofficial, but I anticipate that they will be published in one of the top 2 medical journals in the coming months. And they are, number 1, does the provider provide an itemized bill in plain English, not this crazy code language that we've all become enslaved to by the AMA to pay them a licensing fee on every single bill that gets sent and processed. Number 2, does the center provide real prices for common shoppable services upon request, not just posting machine readable prices on their website? Number 3, can patients speak with a hospital representative promptly if they have a concern about their bill? Can their concerns be investigated, and can that hospital close the loop? You would expect that of any car dealer. If you bought an expensive car from them, they should pick up the phone. They should answer your questions after you purchase the car. People deserve better service quality. Number 4, does the hospital sue patients? Do they garnish wages, put liens on homes, or withdraw money from your state income tax return because you cannot pay the bill? I would call these not bad debt. I would call them unaffordable bills as a result of price gouging. And number 5, how do they treat out-of-network patients? We can get our act together to provide master bills that are honest and fair. And number 6, does the hospital charge patients for serious preventable events? The SREs, as defined by the NQF, are extreme things like operating on the wrong side, leaving a sponge in, death of a patient who's ASA class 1. These extreme, what we call never events, should not be paid for on the backs of the everyday families and victims of these catastrophes. So these are basic billing principles that we are putting out there as ways that we should measure quality, because quality is not just medical complication rate quality, it's financial complication rate quality. So we met with Leapfrog Group yesterday, and they are embarking on this. And I think we're going to see a lot of traction on ways that we can create really public accountability around pricing and billing.
Yeah, that would be a stamp of quality, sort of like the UL stamp on the bottom of a lamp, that I think every honest facility that wants to not just be a medical advocate for the patient, but a financial advocate of patients would seek. That's very interesting. It'll be fun to follow. Sean, are you with us?
Yes, I am.
Sean, tell us about yourself and what you believe. You sent me a message this morning defining disruption. I'm going to let you run with that.
Okay. Thank you, Keith. And thank you, David, for hosting. Good morning, Cristin. Good morning, Marty. So I think I'm the lone non-MD on this. And I have both my siblings are doctors, so I feel like I understand medicine better than most MBAs. But coming up from a business perspective, I think it's useful for us to define disruption. I think it means a lot of different things to a lot of different people. So according to the Cambridge Dictionary, disruption is an interruption in the usual way that a system or process or event works. In my humble opinion, that pretty much sums up our movement, what we're doing as individuals, but then also collectively in the FMMA, the Free Market Medical Association. And so a little bit about us, my brother and I both worked in large hospital systems. I saw particularly where a lot of the money was flowing, and I saw that there was no real control on the price increases on the large system facility side. So we knew that if you worked with quality surgeons, that you could make sure that the patient was taken care of in facilities that were both quality and appropriate and cost efficient. Cost efficient meaning an ASA 1 is taken care of for a lump and a bump in an ASC, an ambulatory surgery center, versus a hospital. And so we started the business, and of course we were blessed with the opportunity to sit down with you, Keith, back in 2016, and asked you some very important questions, which helped us to avoid some of the potholes that I think have caused a lot of pain for other people getting in this. And we based out of Austin, Texas. We sell directly, just as you do, to self-funded employers. And if you want to talk about disruption, from my perspective, I think the model, and Cristin, the model we've developed is really honed to ensure that the patient gets a quality outcome, because we're ear selecting or selecting by other means the specialist, but then we're also making sure that they're seeing the most appropriate site of service, so cost is appropriate. And then we're eliminating a whole lot of the complexity and extra cost that the system puts on every single episode of care. But then where I think the disruption that is going to, I think, transform healthcare in this country is on the buyer side. Now, that includes the intermediaries. And I think it bears mentioning innovative intermediaries that really led the charge and done so at their own peril. And that's guys like Jay Kempton, the Kempton Group, Boone Chapman here in Austin, AMPS, and others, and also Apostrophe, I would say, is a new entrant into the TPA or intermediary market that really helps for employers to be able to purchase directly from providers like us, who are providing not only quality, but also at a very competitive cash price.
Hey, Sean?
Yes.
Is there any way you can get closer to your mic? My chat is lighting up with messages that can't hear you very well, and Cristin has some sort of hearing device up close to her head, so
Okay, is this better?
we're going to need some emergency, well-placed cochlear implants, or I need you closer to your mic.
Can you hear me better now?
Yes.
Okay, sorry. And so I think a lot of the disruption that will occur is both on the enablement side, which is the intermediaries who will allow or provide the enablement both in terms of technology and model for employers who want to get out of the current cartel purchasing methodology and move into a more direct relationship with the healthcare providers who are providing services to their members. And so I think the buyer side is where the real improvements need to occur. Because I'll never forget, Keith, the thing you told me in 2016 was, be careful about investing a whole lot of money in the facility at this point. There's not a whole lot of buyers out there. We're all pushing hard to get more. And I think that has happened, but it's still minuscule compared to what the big VUCA networks drive through their purchasing process. I think that if buyers, they get smart, the employers who become smart shoppers, like they have in so many other domains, they work the supply chain. they'll be choosing quality providers who are willing to put their quality out in front, transparent, like we all do, and at the same time, give a firm price for a set of services. I think Marty brought up something important about patients understanding what they're actually purchasing. And from a business perspective, I look at that as in healthcare, there are very few discernible products. So LASIK is probably one of the best examples. You go in, you get a diagnosis, you have myopia, and LASIK doesn't just mean the operation. It means the entire episode from start to finish because they're competing in a cash market. Now, in that same way, what we do as bundled providers, or direct contract providers, we do the same thing. Keith, you don't sell a minute of anesthesia time to go with that DME or to go with that surgery or to go with that scalpel. You bundle it into products that the patient can understand. They have a diagnosis, and then you have a solution, and that's a well-known treatment that provides that type of outcome that they need. And then you bundle it all into one price so that there are no gotchas, there are no things left off the table. And if there are things left out, it's very clearly stated up front that they're not included and why, but then that information is given to them as soon as that number is known. So it's not a way to gouge. So I think I'll stop right there.
Yeah, and I think you brought up a kind of a subject and a topic that I've discussed many times, and that's sort of the chicken and the egg phenomenon in this industry. As we talk about facilities in particular, and innovation and disruption in facilities, the entrepreneur is always forecasting the future, and the idea that buyers will actually be present to buy whatever the entrepreneur is going to take the risk to create is a critical question and focus. And whenever I talk to employers, large employers, many times they'll say, well, how many people are providing this free market service that's priced this way? And I know people who want to start facilities that are fairly priced and transparently priced, but they wonder, are there any buyers out there who even care, or are there sufficient buyers out there who care? And this sort of chicken and egg phenomenon, I think, is, do the facilities come into existence, with the hope that the buyers show up? Do the buyers make it very clear that they're sick and tired of following the recommendations of their consultant, perhaps, who's lining his pockets with the advice that he gives to self-funded companies, for instance? And I think that we have to keep that in mind, that's part of the loggerhead of why there are not more facilities providing transparent pricing, is because I think they legitimately scratch their head and wonder, do enough people actually care what it costs, in spite of all their complaining? Because there's plenty of people complaining about how much healthcare costs. The ones complaining the most are the ones that receive the bills that Marty and Cynthia Fisher are trying to address. But most people in the country, by design, I would argue, do not have the sticker shock that would invest the confidence in the entrepreneur to go ahead and depart with capital to create a free market facility. But having said that, and hopefully that spurs some discussion, I agree with Marty that there is a real crisis. There's a real crisis in confidence, and it's well deserved. I think the hospitals, the price gouging hospitals that are seen as vicious, mercenary, merciless price gougers, I think that's well deserved. But is that not an opportunity? I see a hospital system in Oklahoma City, for instance, amongst the several hospital systems here, being able really to distinguish themselves in the marketplace by being fair and honest with patients about pricing. And I would think that if I were running one of these hospitals, I would see that as a market opportunity. So I'd like everybody's opinion on that. I mean, in big cities, in particular, where there are multiple competing hospital systems, do you think that idea that, I'm gonna stick out, I'm gonna not rip people off, and that actually is going to be better for my business? Does that make any sense at all to any of the panelists? Marty, start with you.
That's really the way the free market is supposed to work. Patients should be rewarding good actors and good behaviors. The problem is they're walking into a black box, and as long as patients are picking hospitals based on who's advertising at the NFL stadium and who's got parking, we don't have a competent marketplace. We do have competition, but it's at the level of advertisements, billboards, and valet. It's not at the level of quality and pricing. That's real value. So I think we need to enable the vehicle for people to be able to make decisions, and that is sort of like nutrition labels. When we wanted nutrition labels, the industry, if you remember, the food industry said, we can't do this, it's impossible, there's too many ingredients, nobody can get this information, and if we do, it'll cost so much, food prices will spike. Well, guess what? None of those predictions were true. We got nutrition labels, and now people shop for food based on nutrition. And companies boast about their low sugar and their nutritional ingredients. So it's not unlike travel websites. If prices, if you think about the price from a flight from where I am, Washington, D.C. to Florida, in 1979, cost $200. Today, it costs about $250. You talk about a stable market where competition has enabled checks on prices. I mean, that's remarkable. You talk about minimal inflation over the course of 40 years. And travel sites have been that vehicle to enable people to shop. If airlines billed us after the flight and didn't have to show prices, guess what? They'd be price gouging us left and right. You'd have stories looming in the United States. You'd have not just a bill of the month series at NPR, you'd have a bill of the hour of United Airlines charging somebody $50,000 for a flight from Philadelphia to Chicago, and a surprise bill for $800 for a Coca-Cola. That would be the incompetent marketplace we would have if you had this system where prices were only disclosed at the time of billing. And when patients asked, hey, how much is this going to knock me down? They would be given the standard runaround that hospitals have been giving for 50 years. Look, I don't think personally that we have bad people running American hospitals. I actually think we have good people in a bad system. These are people that have inherited this crazy game, this insane game of artificially inflating prices for the purposes of secret insurance discounts as a part of a rich man's game, where all these special interests are doing quite well except for one, and that's the patient. So rather than, the blame game which we see go around in healthcare, I think we need to look at this system that we've inherited and say, this system could be better, be a leader, do some cool things. I just talked to a hospital CEO in Nashville, and this hospital CEO said, we're going to post our prices on MD Save. We're going to renegotiate our hospital contracts with the doctors groups that come into our hospital to make sure they don't surprise bill. And if they send a separate bill, it's in line with the in-network price. And they provide minimal and transparent discounts to insurance companies. And I thought, here's a step in the right direction. Here's a leader. This hospital should be rewarded over the next hospital that may say price gouge and even engage in predatory billing.
Yeah, and one of the Austrian economic concepts that was so radical, that was so disruptive, was the idea that the customer is sovereign, and that none of the arguments by the suppliers of a good or a service none of their concerns should really even be addressed. It's only the consumer that should be the focus. And I think that's part of what people need to keep in mind when they hear some hospital administrator in a $5,000 suit saying, but our costs are so high. As Jay Kempton has said many times, in what other industry are the problems and issues of the seller the problems of the buyer? And the buyer, I agree, needs to be sovereign. I think Cristin has stepped up and has seen the price gouging all around her as an opportunity. I will say we have at the Surgery Center of Oklahoma. Cristin, do you want to comment?
Yeah, I do. And I agree with you, Keith, that one of the biggest problems we have is willing providers. And there are a number of reasons for that. There is the fear factor. But the biggest issue is that doctors don't understand that they're spending 30% of their revenue to collect 70% of what they're contracted to receive from these quote unquote insurance companies. And when they're educated about that, they understand that, we can fairly charge a reference-based pricing or just a flat fee and do so much better and not be subject. I can't tell you how much time I spend arguing against auths, against pre-authorization. There is absolutely, I see no difference in my, when I have an auth in place with a direct contract compared to a one without it. I see no difference in utilization. It's just a hoop that doctors have to jump through that drives up the cost of medicine. And I think one of the biggest issues is, and this is part of the sick system, is that almost 70% of doctors in this country are either subsidized by or employed by a hospital system. That's one of the things that's broken. And the cost of care all the way up throughout the episode of care is at least three times greater. And in a lot of cities, it's 9 times greater in these cities that are dominated by hospital systems like Boston and Pittsburgh. And that drives up the cost of care all the way through somebody's episode of care. And that is just what we have to do is we have to incentivize these people to find the independent doctors, to find the independent imaging centers, give them ready access to this kind of care, so that we can change the system.
Yeah, I agree with you. The hospitals owning physicians is a real issue. John Chamberlain, I believe, who's participating, has told me that much of this purchase of physician practices has been fueled by the facility fees that the federal government allows the hospitals to charge, and also the site non-neutrality, where a hospital outpatient department, for instance, bills multiples and collects multiples even from federal payers for the same service provided at a facility like mine. Even as the topic of site neutrality is being addressed properly by the federal government, there's some hope and even some sign that hospitals are shedding themselves of the physician practices many of them have bought. I'm old enough, I remember the extreme push back in the 1990s in the early 2000s to ban physician ownership of any facility. And a friend of mine very wryly said, I guess it's okay for hospitals to own doctors, but not for doctors to own hospitals. And of course, this is a throwback for physicians to own facilities. That's the way many, if not most, facilities in the United States, when you look at hospitals, that's how they were founded, was by the physicians who worked there. I'm getting messages, and I think the other panelists are too, about some of what we're discussing. One of the messages that I received was with regard to the growth of this movement. And a comment I would like to make, just as in the last panel, they brought up the idea that actually posting prices and price transparency will drive prices up, and how ridiculous that is. I think we can probably all agree on that. We may want to discuss it. The other point the detractors would like to make that I've seen has been led by the liar and idiot Jonathan Gruber from MIT, who's saying even armed with price and quality information, patients will not make the right decision. So, number one, let's not get the information out there. And number two, even if patients have it, they will not know how to use it. The third detracting and distracting comment I think that's made about the innovation and disruption that's occurring, which I found very interesting, is criticism of the lack of participants in this free market movement. And I would say that there are as many people participating in this free market movement as there are, given the obstacles, is truly astonishing. Are there any of those 3 points, Sean, you care to respond to?
Yeah, I'll tell you what, Keith, I completely agree with, I'm very surprised that Marty mentioned a hospital in Nashville that was willing to do some of this stuff for the reason that I think Cristin brought up, and then also you and I have talked about in the past, Keith, is that it is really hard for a facility who receives 95% of their revenue from a couple different sources, and those are big VUCA contracts. And then you're getting that money, it's the beginning point of the dollars coming from an employer, but their intermediary, for all intents and purposes, that's why we call them a payer. They're not paying anything in most sense. They're just passing dollars through. But because of that, everyone knows how important they are. And it's unstated sometimes or stated, but it is very critical to decision making from an entrepreneur to take risk on a facility. Why? Because if you're going to take risk on building a facility that's going to expose prices, there's going to be pressure put on you by the VUCA carriers. They're going to come to you and say, well, those are our patients. They're coming to you from employers that have a network, and they're taking them out of a network, and we're going to challenge you on that. In fact, we're going to cancel our contract with you. For most providers today, with margins where they are, based on what Cristin was saying about the 30% off the top, there's no way that you can let that revenue go today. So it's really hard. The switching costs are incredibly high for existing facilities, and almost impossible right now for an entrepreneur to seriously consider doing a cash-only facility. You know this from your experience. You've been doing this since 2009, I believe, 10 years now, and up until very recently, you still had contracts. It's a hard switch. Now, I do think, though, that the issue around facilities getting into the free market, there needs to be, so facilities have to know their cost as a basis for how they're going to price. And most of them have no idea what the costs are. So I brought an accounting methodology that I had worked with in 2 other previous industries in my career. I brought it to healthcare in 2005. Everybody told me, no, go down the hall, the cost accounting department's down there. And when I got there, I was totally surprised, because it is not what any accountant would call cost accounting. It's the hospital system's lovely little fiction about what things cost that they give to Medicare so that they can increase the amount of money that they get from Medicare. You can imagine how tight those costs are. They don't reflect reality in the least. But I brought time-driven, activity-based costing with me. It didn't work within the hospital system. No one wanted to hear about it. No one thought it was important, because pricing was independent of cost. Now, if you're going to compete in any business based on price, the smartest way to start is to understand your cost and add in a margin and see where that compares with a market price. You might find that there's actually a huge opportunity there to make a good margin and still undercut the existing prevailing market price. And that's where I think we are. We, Keith, Cristin, we all three know what our costs are. We know to the minute. And therefore, because of that, we can price to whatever purchaser that comes to us, any new service. On a daily basis, we have people call and say, well, I didn't see this on your website, Sean. Could you price it for us? Sure, let me let you talk to our nurse. Get some of the clinical information, 15, 20 minutes later, we've got a bundle put together. Now that presumes that we had contracts and everything in existence with the specialists, the facilities and others that needed to complete the episode of care. But we've got quite a few of those, as you do, Keith. So if somebody calls you today and asks you for some esoteric procedure, you could come up with a bundle pretty quick. Well, it's because you understand your cost. So you're not really taking any risk when you price because you know. Now, hospitals stepping off of the curb into the road. I don't know many hospitals that know their costs. And if they get smart, they will learn that cost. And then they'll be in a much better position. I know that our chief medical officer came to us from Baylor Scott and White. He was chief of orthopedics before he left, Dr. Schultz. And one of the stories he tells is they did bundles, and the only bundles they did were the CJR, the Comprehensive Joint Replacement Bundles for Medicare. And he said when they tried to do another bundle, it took 12 months and they never got to the price because there's so many disparate parties within a system trying to put in their 2 cents about what things cost. So as a starting point, if you're a facility and you're thinking about this, know your cost. Now, what I've learned in the market is there are a lot of surgery centers who do know their costs. And they know them very well because they need to be cost conscious based on their revenues that they get today compared to most of the hospital facilities. But if you have that information as an exercise, just figure out what a bundle costs. You know, do it on a prospective basis, just within your own organization. Figure out what those top 10 procedures are going to cost you. Figure out where all the money is flowing out for each and every of those procedures, and then go out and compare them to what's on the market at the fmma.org site, the Shop Health tool. And you'll see there are not a whole lot of providers in this country. They're all aggregated there, but they're all over the country. But just take a look at it and see how you compare. I think you'll be surprised at the number of people who've figured out the cost, and your costs are pretty much the same. And then if you can get the information, and I recommend going to the Healthcare Cost Institute's bundle pricing website. It's called guru.com, GUROO.com. And they do, I think, about 80 different care bundles. And they do it based on insurance, employer-sponsored, self-funded insurance payments. So it's allowable. In major markets across the US, it's like 61 million lives, I believe. So you can look at their bundled price and say for a total knee or a total hip, it's around $40,000 in our market. Well, Keith, I know yours is around $15,000. Ours is $19,000. So I think you'll have the same kind of aha. If you're a facility owner or a doctor who's a partner in a facility, I think y'all have that same kind of aha of like, wow, there's a real opportunity for us to compete in this space. Then
Marty, I want to get back to comments you made about Nashville. I testified before a working group on certificate of need a couple of days ago in Tennessee, and I was shocked that they wanted me to testify. And I think one of the senators that was in the room is actually an employee of HCA. And so I was unhinged in my comments knowing that. And after hearing all their excuses for maintaining certificate of need in Tennessee, and listening to all the pushback, I recommended, in spite of their inviting me to testify before them, I recommended that they maintain their CON, certificate of need, and even toughen it, because that would ensure that even more patients from Tennessee would come to Oklahoma for their surgery. We had a patient come from Vanderbilt about 4 months ago, a family with their 4-year-old, and he needed a circumcision. And they were quoted $21,000 just for the facility fee from Vanderbilt, and our all-in price was $1,800. And these parents were members of a cost-sharing ministry, and they went back to Tennessee and they began to talk, and the word spread, and it was not a good day, I don't imagine, for Vanderbilt. But what I'm coming around to is back to the growth of this movement. I would say that this movement is growing, even though in many ways that it's cloaked. I think the market is pushing even the Baylors and the Vanderbilts, and in my area, Integris, it is pushing them to embrace at least some parts of what's going on, however cloaked they would like to be. I think that hospitals are feeling the pressure when a patient throws down a price for a total joint at a transparently priced facility. Match this, or I'm flying to Austin or Oklahoma City or Bill Grant's place in Virginia or wherever they're going to go. Marty, what's your reaction to that? Do you agree with me that maybe behind the curtain, the market pressure is actually having an effect, the measurement of which may at this point be very difficult?
I do, because what I see is that big hospital systems that were laughing at you, Keith, in your surgery center of Oklahoma, are now frightened. And they're now realizing, hey, we need to get our act together and actually figure out how to itemize a true price for some of these services, because it's no longer a joke. We're now losing business to the Surgery Center of Oklahoma. And that's what I'm seeing in different pockets around the country. That is a great American revolution. And it's sort of a tea party of healthcare, if you will. It's not a partisan endeavor. It's a free market endeavor. And take a look at the hospital that I was referring to, which, by the way, is St. Thomas Hospital. Nashville is a competitive market with some giants there. And this hospital has Healthcare Blue Book come in to make sure their prices are close to reference-based prices. They've renegotiated the contracts with the doctors to ensure there's no money games with surprise billing. They have posted prices now on mdsave.com, which is a Nashville company. There are many sites that are now becoming kayak and Travelocity sites for services. So it's a revolution. We referred earlier to this idea that patients may not use pricing information. And I posted an article that addresses that criticism on the chat. But let's remember, the big money game of the big hospitals is something that really no one knows much about, that we are not talking about as a country, that we need to talk about. And that is a legal clause called an all or nothing provision. And so what's happening in these money game negotiations between hospitals and insurers is that the hospitals say, if you want to do a contract with us, you have to go all or nothing on all of our clinics. So if we are, say, Vanderbilt Medical Center, you have to pay us this standard marked up price or whatever that negotiated price is at every single Vanderbilt center around the world. And they insist on it. Well, guess what that incentivizes? The big Vanderbilt goes and buys some sleepy hospital or some sleepy, fairly priced surgery center or physician group. And all of a sudden now they are part of that all or nothing contracting, where that little low or fairly reasonably priced clinic or physician group is now getting paid at those high Vanderbilt prices. And it's the easiest way to make money in the world. If you're a hospital, buy a clinic, buy a practice, and all of a sudden now you're getting reimbursed at those big academic mega center prices. And so that is the game. And that's why these hospitals are buying up everything. And the reason I say this is not so we all get depressed. It's because it just highlights that the kryptonite for this crazy rich man's money game is price transparency. It disrupts that marketplace. It completely disrupts that marketplace. And so that's why we need to advance these ideas, because when people are looking for care, and they see that there's a fair and reasonably priced clinic that provides honest, solid medical care, that is going to steer the patient around these money games.
Yeah, as Gandhi said, first they ignore us, then they laugh at us, then they fight us, then we win. And I think it's playing out very much like that. I know that I'm seeing it in this region. Cristin, I want to get your thoughts about what competition looks like for you in the hospitals that are in areas where you have centers. Are they responding to your pricing as much as they say that is an impossible thing to do?
We don't see that at all in the hospital systems. And in fact, I just reviewed claims for a 10,000 employee school district. And we found 10,000 employees, mind you. We found 600 MRI and CT scan claims that were paid that did not have CPT codes, which is against the law. They can't do that, but they just had hospital codes. This is 600 for a group of 10,000. These were paid out between $2,000 and $39,000. Now you could say, okay, some of these may be sedation cases or complex angiographic cases, not 600 for 10,000. And this was a traditional TPA, so this is one of the BUCA plans, and this is robbery. Think of what this is. These families have a $6,000 out-of-pocket maximum. So this was a financial crisis for 600 families. And it makes me ill. And, I do think I don't think it's a free market when you have no ethics. Free markets don't work. And so there is something going on. I don't believe that most people consciously think about that this is all wrong, what the hospitals are doing. I don't think the administrators consciously do this. I think it's a self-preservation. The system is so broken that they just continue to do the same things they are just to preserve the income streams they have. And I think it's going to take the people like us getting these people out of the hospital systems. That's my whole goal, is to get 80%, 90% of care out of the hospital systems. That's what's going to catch their attention, and that's what's going to create change.
Yeah, and the hospital administrators and the people running these vicious price gouging facilities won't do the right thing because it's the right thing. The people on this panel will do the right thing because it's the right thing. The vicious mercenaries will do the right thing because the market will crush them if they don't. Years ago, you all probably have all heard of Walter Williams, economist from the Mercatus Center, and my dad asked him a question after a talk, and he said, "Are these legislators ignorant or evil?" Because take your pick. As bad as things go, and most things government, if not everything government gets involved with, are these legislators ignorant or evil? And Walter Williams says both, and they're arrogant. So a real bad combination. And Marty, I'll push back a little bit. I would say, I would maybe agree with you that some hospital administrators are not evil, but I would say that they are thoroughly enjoying and profiting from a system that is broken. They have all the power in the world to push back. And while many of them are not evil, that's my default. Because at this point, with this movement as just astonishingly large and prominent as it is, partly because of the work of people on this panel, there's no way you can claim ignorance. There is just simply no way that a hospital can say anymore, well, we don't know what our costs are. Well, of course they know what their costs are. And so my default position is that these people are taking advantage of a broken system, know exactly what they're doing. What the CEO of a large third-party administrator years ago was summoned to a large hospital here in Oklahoma, and the hospital administrator told the CEO, I'm ready to match Surgery Center of Oklahoma's pricing as long as you exclude them from this game. And the CEO said, well, I think I know how long that price match would last after I agree to it and walk out the door. So I think these people, most of them know exactly what they're doing. I am very anxious to see any and all of them prove that they know what's going on and they want to join us to change it. I don't think we have to mandate that they change it. I think the market is going to crush those who don't come along. We've got, it looks like 10 minutes left. I would like the comments of the three of you on the last issue that popped up in the last panel, and that is on mandating through legislation price transparency. Everybody take about a minute to respond to that. I'll tell my views when we're done. Marty, go ahead.
Well, look, I don't have a lot of faith in the government. Forgive me, I live in the swamp of Washington, D.C. And so, look, I think the best solution is if we get people to demand this. And it doesn't have to be individuals, although that is driving some market change right now. It's also proxy shoppers. It's employers, it's TPAs, it's groups that purchase healthcare on behalf of individuals. If we all demand price transparency, I think we're going to start to see the market reward it because hospitals want business. And so, I couldn't agree with you more on your comments earlier, Keith. We have too many people in healthcare just picking up their paycheck every 2 weeks. And those paychecks get bigger and bigger as the games get, more egregious. And I'm a cancer surgeon. I'm reminded how short life is every day. We've got to speak up. People are getting hammered out there. 50% of Americans have $400 of cash in their savings account or less. People are getting crushed. They don't live like us in the medical establishment. People are getting crushed out there right now. So we've got to speak up and we've got to demand better. When we ask hospitals in the most extreme form of predatory billing to stop suing patients, and we go around the country through our movement, restoringmedicine.org, which is a part of this coalition, we're often told we have to sue patients in order to stay financially solvent by the hospital. You know what? All of the money they collect from garnishing paychecks is less than half of the CEO pay in 1 year. Give me a break. We need some honesty and some ethics back in healthcare.
And I would say that movement is more powerful in pointing out the need for price transparency than anything that could be achieved by mandating it. Sean, do you take a minute and give me your thoughts on mandating price transparency?
So thank you, Keith. So anything involved in healthcare, when we start talking about the government, I think it's important for us to know that the healthcare lobby spends more than all the other lobbies combined. So when I get asked, I live in Austin, Texas, the capital of Texas, where the legislature's in session every 2 years, thankfully just once every 2 years. And when they are, boy, I get lots and lots of people calling and saying, Sean, would you come up and talk? I'm gonna get this bill. I want to mandate price transparency, quality transparency, et cetera, et cetera. And so far I have rejected all those invitations. And the primary reason is because the cartel lobby will get involved and they will make it about me. They'll make it about something else than the transparency that was necessary for a right functioning free market. And they'll distort it. If it gets passed, the title of the legislation will say something like Price Transparency and Fairness Bill. And you and I both know that what the bill actually will look like, it'll be so distorted as to mean nothing. So I like the price transparency that we're starting to see from the federal level. But because the charge master is broken down into such tiny little incremental supplies and services, it's unintelligible by anyone, including the people at the hospitals. So they can't even put together an episode of care out of that. So I think the price transparency has to go along with the development of service bundles, episode of care bundles that actually are relevant to what patients are seeking. Without that, and in our industry, that's a bundle. Cristin knows, somebody calls and they say, I've got this diagnosis, I need this kind of image. She knows exactly what that is. She bundles it up and there's a price. Same thing with you, Keith. Somebody comes to you. You bundle everything in it. You don't just leave out certain things. But that's, in my jargon, or at least from my economics training and my business administration training, that's a product. That's something that a purchaser can look at and compare across different facilities or entities or sellers. And then they can compare cost and quality. But without that, it looks just like noise. The only thing I ask people from government when they say, well, what should we do? The only thing I tell them is you ought to open up all government healthcare purchasing and obligate them to at least get competitive bids where there are participants in markets that are offering bundled surgeries or bundled services.
Yeah, when government asks me what they could do, I tell them to stay home. Cristin, we've got just a little bit of time left. What are your thoughts on mandating price transparency?
I think the best price transparency is actually claims data. And what about government claims? You know, they're employers. What about that claims data? Shouldn't we all have access to that? There's so little bundling going on out there that really pricing transparency. Nobody's going to, if you list a bunch of CPT codes, nobody's going to understand how to bundle those together and come up with a price. I think we're barking up the wrong tree. I think mandating that we get to, as citizens of this country, see claims data and see what's really being paid and what's really, when I show employers what they're really paying for imaging, the light bulb goes on, and the fact that they can drop that by 2/3, comprising about 8% of their total healthcare spend with just a bolt-on plan like vision or dental, making us a preferred provider, the light bulbs go off everywhere. And what they see too is they see their employees struggling and seeing everybody struggling with health care costs, and they want to make it better. They really do, and there are easy ways to do that. And I think rather than mandating, I think just continued education and pressure. We have the much data. I can show you, bundles and bundles of them, and it's there for our taking, and I think that's what we need to focus on, not mandating hospitals. They're going to hide it the best way they can and make it unable to really decipher and understand, just like they have so far.
Thank you. We're almost out of time. I'll give you my thoughts on mandating price transparency. I believe that it's a particularly bad idea because it will afford unscrupulous legislators, which is almost all of them, the opportunity to sell exemptions, basically sell indulgences. It also will provide the big dogs in the room the opportunity to redefine price transparency to suit their needs. When I made these comments to Cynthia Fisher last year at FMMA, she wasn't really sure she agreed with me, and I told her, I said, yeah, the other thing you have to keep in mind is, redefining price transparency will become what is the patient's out of pocket. And she confirmed that was exactly what the thugs, lobbyists in our industry in DC were trying to do, was define price transparency as what is the patient's out of pocket, not actually what does it cost. So I think we have to be very cautious with that idea, acknowledge the extent to which this movement has exploded and continues to, largely due to the work from people who are on this panel. And I would like to thank all of you for your time on this Saturday morning and participating, and David Ballett and everyone who arranged this. Thank you very much. These are all important concepts, and it's good to get this word out.
Thank you, Keith.
Thanks, Keith.
Thank you all. Good to see you all.